Hi everyone, my name is Megan Brown and I'm a nurse practitioner student at Auburn University. I'm going to be performing my head to toe assessment on my patient Zach. For the purpose of this video, we will maintain patient privacy, so he will be staying fully dressed and will not be in a patient gown. For the purpose of this video, we will also just be performing the head to toe assessment on one side, but normally you would be doing this bilaterally. So I'd start off by, when he walked in the room, we'd be looking at his gait, his posture, his general appearance, the skin color, noting the general appearance of his overall skin. We would also be looking at hygiene. We could tell also just by the way he spoke and answered my questions about his neurological status. So we start off by inspecting his head and his scalp. We'd want to look at the contour of the skull, at the hair, overall hair distribution, if there's any infestations in the hair, any tenderness, any redness, any bulges, any masses. So you go ahead and palpate anything tender.
No.
After that, we'd move on to the eyes. So we'd be looking at his eyebrows, at the distribution of hair, at his eyelashes. We would know any redness in the conjunctiva, make sure his lacriminal glands are patent. From here, we could go ahead and check on cranial nerve number 2, which would be the with the Snellen eye chart for visual acuity. So we'd stand 20 feet away from the patient and have him read the lowest line he could on the Snellen eye chart, and then also do near sight vision on a smaller card. So once we did this, we then do our ophthalmoscope exam. So we'd be looking at the internal eye. So we first want to look at the corneal reflex and the red light reflex. So I would make sure to have this in my appropriate hand. So if I'm looking at his right eye, I would be using my right hand. If I'm going to look at his left eye, I'd be using my left hand. So there is a red light reflex. We'd also be looking at visualizing the optic disc, making sure that it's a yellowish orange color at his the fovea, the macula, and any arteries and veins to know any narrowing in his inner eye. From here, I could have him to also check for visual acuity. We'd have him follow the pen light. We would know any nystagmus, that his corneal reflexes are intact. We could also do perla, which would be looking at pupils equal and reactive to light. We notice that his pupils do react to light appropriately. From here, we would then go on to the nose. We would inspect the nose for any redness, any obvious drainage. We would palpate it for any tenderness, and while we're here, we could also go ahead and palpate the maxillary sinuses and the frontal sinuses for any tenderness. You could also percuss these, and we could also use the pen light to transilluminate the sinuses as well. So back to the nose, we would then have him lift his head up. We would want to go ahead and visualize the inner nose. We want to look at the nasal turpentines, make sure there's no septal deviations, make sure everything's pink and moist, that there's no obvious drainage, no septal perforation, anything like that. From here, we could go on to the mouth. So we want to go ahead and inspect the lips for any cracks, make sure they're pink and moist, make sure there's no disease processes going on. I'd have him open his mouth. We take a look at his gums, that make sure they're pink and moist, no bleeding noted, that the mucosa is pink and moist. We don't look at his teeth to make sure there's no obvious broken teeth or anything like that. We look at his tongue. We'd have him stick out his tongue, say ah. Here we could also check the gag reflex, which would be cranial nerve 10. And we would want to look at the uvula, make sure it's midline, and the tonsils. From the mouth, we'd go on to the ears. So we would first want to inspect the ears and make sure that they're any for redness, any masses, any bulging, especially around the lymph nodes. We'd also want to make sure there's no drainage coming out of the ear. You'd want to palpate the pinna and the truncus for any tenderness, any lesions, any masses, any tenderness.
No.
And you would do this bilaterally. So then we'd go ahead and look in his ear. So we'd pull the pinna up and back. We want to go ahead and visualize the inner ear canal and the eardrum. Look for any foreign bodies, buildup of earwax, any drainage. Make sure that you visualize the eardrum. And you would do this again on both ears. So you pull the pin up and back. And again, you'd want to visualize the inner ear canal and the eardrum. With hearing, we'd go ahead and do the Weber test. So this would check for lateralization of hearing in both ears. So I'm going to have you tell me when you can't hear the ringing anymore, okay? Okay. And then we'd also check behind the ear, and then we check air conduction. Okay. And you check this on both sides. Okay, and we would notice that the air conduction is longer than bone conduction, which is normal. From here, we could also check cranial nerve 8, which is the whisper test. So I'm going to stand behind you. I'm going to whisper something, and you need to repeat it back to me, okay?
One B2.
3, 4.
3, 4 M.
And we would note that the hearing is good in both ears. And again, that's cranial nerve 8. After we're done with that, we're going to move on to the neck. So, and he has facial hair, so it's going to be a little bit more difficult. But we would first inspect the neck, make sure the trachea is midline, notice any skin discoloration, any redness, any masses. We'd go ahead and palpate the trachea, any tenderness.
No.
You would want to stand behind the patient, have them swallow, and go ahead and feel for the thyroid. Swallow for me. Good. In the neck, we can also go ahead and do our lymph nodes. So you have your occipital lymph node, which is behind the head. You have your post-auricular, which is the ear. You have your pre-auricular. You have your tonsillar. You have your submandibular and your submental. Then you have your the cervical chain. So you have your superficial cervical, your deep cervicals, and then your posterior cervicals, and then clavicular lymph nodes. Any tenderness? So after that, we would go ahead and go to the back of the patient. So for the purpose of this exam, he will keep his shirt on, but normally the patient would have their shirt off. So you'd go behind the patient and you would palpate for any tenderness, inspect the skin for any lesions, any redness, any bulging. And then that was noted. You could go ahead and percuss the patient's back. So you do this in a zigzag, noting any hyperresonance or resonance. And everything sounds very tympanic. You could also, then you would go ahead and do the tactile fermentus, so say 99.
99.
Say
99.
Say 99.
99.
And then you'd stand behind the patient. Take a deep breath in. Let it out. And you would also want to notice any CV tenderness while we're back here. After that exam, we'd go ahead and listen to the lung sounds with both the diaphragm and the bell of the stethoscope. Take a deep breath in, let it out. Deep breath in, let it out. Deep breath. Deep breath. Deep breath. Deep breath. And again, you would do this with the bell and the diaphragm of your stethoscope. You'd follow that zigzag pattern. From the posterior thorax, we then go to the anterior thorax, and again, you would be inspecting the chest for any obvious masses, any bulging, any lesions. You would do the tactile fermentus again on this anterior side of the chest. You would percuss, noting tympany. Obviously, having the patient tell you if anything's tender. If you noticed any hyperresonance, that would be a good sign, and any crepitus could be a sign of emphysema. After percussing, you would then auscultate again. You'd listen to the breath sounds. So take a deep breath. Deep breath. Deep breath. Deep breath. And again, you would do this with the diaphragm and the bell of your stethoscope, listening to breath sounds. We would then move on to the heart sounds. So again, you would want to notice any unusual pulsations. If you feel any tenderness, again, have the patient let you know, so then you'd go ahead and listen to his heart sounds. So you're going to listen to the apical, pulmonic, Erb's point, mitral, and tricuspid. And you do this with the diaphragm and the bell of your stethoscope. Moving on from that, you could go ahead and do your pulses. So you could do your temporal pulses. You want to palpate, and you could also auscultate and listen. You'd want to do your carotid pulses, and you do this unilaterally. You would not hold at the same time. You do the brachial, your radial. You'd have your femoral pulse, your popliteal, which is behind the knee, posterior tibial, and then pedal, which is on the foot. You'd want to note that these are 2+, which is a normal finding in patients. Okay, from here we're going to have the go ahead and have you lie down, and we'll do our abdominal assessment. So you'd want to inspect the patient's stomach for the contour, any pulsations. You want to note peristalsis on the stomach. After inspection, you'd go ahead and auscultate. So you're going to listen for bowel sounds. And you'd want to listen for a full minute in each 4-quadrant. While you're listening, you could also go ahead and listen to the aorta, the iliacs, and the arteries in the kidneys. Once you're through listening, you can go ahead and then percuss in all 4 quadrants. You could palpate. You do light and deep palpations. You then have your patient take a deep breath, let it out, and you go ahead and palpate that right into that right upper quadrant for the liver. And you then could do the same on the other side for the spleen. While your patient's lying down, you can also do your abdominal reflex, which is normal. You can then raise the head of the patient's head up some. You'd have your patient turn their head to the side. You note any jugular vein distension from here, which he does not, which is normal. while your patient's laying, you can do some range of motions. You can have him take his leg and cross it, noting any hip. And then you do this on the other side. Okay, good. You can have him take his knee in and take it out. You can have him flex his ankle. Okay, good. Okay, go ahead and sit back up. Okay. So after you do that, we could then go ahead and check patient's reflexes. So you do your brachioradial reflex. And then you go behind the ankle and check the Achilles as well. And you would do this bilaterally on both sides of the body. Go ahead and have you stand up. Like I said, we already have assessed his gait and his posture when he walked in the room. You can have him go ahead and walk a straight line for me. Good. I'll have you walk heel to toe. And then walk back. Have you walk on your tiptoes. Good. Raise your shoulders. Put your arms out. Raise your arms up. Okay. Raise them down. Flex at your elbow. Flex your wrist. Spread out your fingers. Like this. Okay. Can you bend down? And that's a good way to check their spine as well. Pick up your knees. And then check for the Romberg. Romberg, you're going to have your patient close their eyes. Their arms out, and put one leg up. And you want to go ahead and check their balance. Good. Okay. Sit back down. So that would be reflexes and the musculoskeletal system. From here, we could go ahead and do his cranial nerves. So for cranial nerve, one would be checking their sense of smell. So we'll have the patient close his eyes and identify what he smells.
Alcohol.
Okay, so that's an alcohol swab. That'd be the cranial nerve number 1. Cranial nerve 2 would be the Snell and Eichard, which, like we said, we would have been 20 feet away from the patient. He would read the very bottom line. He'd cover his right eye and read it, cover the left eye, read it, and then with both eyes, he would go ahead and read it. Cranial nerves 3, 4, and 6 would have been the cover the eye test. So you'd have your patient go ahead and cover your right eye, or your left. You notice, okay, cover your opposite eye. And go ahead and open. And you would know pupil deviation or any nystagmus was noted for 3, 4, and 6. You would also do the static wiggle test. So cover your left eye, and I would cover mine. And tell me when you see my fingers come in, and how many fingers?
2, 3, 1, 4.
Okay, and then you'd have him do this on the opposite side.
1, 2, 4, 2, 1.
Okay. And you would want to notice any nystagmus or any deviation from that. Cranial nerve. You could also have him follow your pen light, which I think we did. Good. To notice as well any extraocular movements. For cranial nerve 5, we'd have you raise your eyebrows, smile, frown, puff out your cheeks. So cranial nerve 5 is intact. We'd also, I'm sorry, that was cranial nerve 7. That's cranial nerve 7. Cranial nerve 5 is would be the sharp or dull test. So I have the patient close his eyes and tell me if he feels if it's sharp or if it's dull. And also, not only if he feels it, but where he feels it. Is it sharp or dull?
Dull on
Where?
my forehead.
Okay.
Sharp on my cheek. Dull on my nose. Sharp on my cheek.
Okay. And then you could assess that cranial nerve is intact. And like I said, cranial nerve 7 would have been, he raised his eyebrows, he smiled, he frowned, and he puffed out his cheek, and that was intact. Cranial nerve 8 was the whisper test, which we did earlier. Cranial nerves 9 and 10, you'd have the patient stick out their tongue, say ah. You check their gag reflex, that is intact. Cranial nerve 11 was the shrug your shoulders, raise them, okay. And you move his head, move your neck from side to side, front and back. That was intact, and we did that along with the musculoskeletal exam. You'd also rate that on a scale of 1 to 5, 5 being the best and the normal. Cranial nerve 12, you'd stick out the tongue and have the patient say, have the patient stick out their tongue, move it from side to side, up, down, and that's intact. Also, you could check their voice with cranial nerves 5, 7, 10, and 12. I'm also going to have you hold out your hand, close your eyes, and tell me what's in your hand.
Paper clip.
Okay, and that is intact, so that is correct. And that is the end of our head to toe assessment. Thank you.